As we discuss the question that infant present to emergency department with high level of the bilirubin and that present since the birth, and there is no sign hemolysis and no abnormal physical activity are present. We got true option these questions. On further discuss, we find like that this case of the hyperbilirubinemia syndromes. Okay, then first condition is Kigler-Nagar syndrome type 1. Mainly in this case, there is mutation in the gene UGT1 and A1. UGT1 A1. Okay. In these conditions, there is complete absence of the enzyme called UDP gluconyl transferase activity. Okay, due to which there is increased level of the unconjugated bilirubin in the body, but decrease in the level of the, or we can say that complete absence of the conjugated bilirubin in the body, because due to deficiency of the enzyme UDP gluconyl transferase in the liver, there is no conjugation happen. Okay, then what clinical features mainly present a patient with Kigler-Nagar syndrome type 1, as this present from the birth. Okay, means a childhood or infant present with severe jaundice from the birth. Okay, and there is high level of the hyperbilirubinemia on lab report, and high risk of chronic tears also with neurological damage. Okay, then what are investigations can you perform, and what you see on investigations on patient with these Kigler-Nagar syndromes? So we can say that high level of the unconjugated bilirubin, but there is complete absence of the conjugated bilirubin. Okay, and as there is no sign of the hemolysis. Okay, there is no sign of the hemolysis, and also no response to phenobarbital. But why? Because there is no bilirubin UDPGT activity, that's why. And bile is pale or colorless because no bilirubin gluconides in the bile, that's why. And how manage a patient with Kigler-Nagar syndrome? So patient with Kigler-Nagar syndrome manage with lifelong phototherapy, but there is no preventive neurological damage, then we go for liver transplantations. Okay, and next is Kigler-Nagar syndrome type 2. This is mainly present in adulthood. Okay, and in this case there is no complete absence of the UDPGT activity, means there is a mild reduction in the UDP gluconide transferase activity only. Okay, only mild reductions, no complete absence. So we can say that there is a increase in both conjugated as well as unconjugated bilirubin in the body. Of course, there is increase in both conjugated as well as unconjugated bilirubin in the body. On clinical features, there is uh, connectors only possible during stress conditions or illness or surgery. Normally not present connectors like in case of Kigler-Nagar syndrome type 1. Okay, in this case also there is mutations in UGT1 and A1. Okay, and on investigation what are finding can you see? So we can say that there is increase in both conjugated as well as unconjugated bilirubin. Okay, and as there is not complete absence of the UDP gluconide transferase activity, so in response to phenobarbital, there is decrease in unconjugated bilirubin level. And as in the type 1 kidney syndrome, there is bile is not contained gluconide, but due to the some activity of the UDP gluconide transferase, bile contains bilirubin monogluconide. Okay, now how manage the patient with this type of syndromes? Then, as phenobarbital therapy that induce the residual UDGPT activity, means UDP gluconide transferase activity. Simple. Okay. Next is Duvin Johnson syndromes. This is a also bilirubin metabolism disorder. Hey, and this is present in only adulthood. Okay, and there is elevation of the conjugated bilirubin in the body. But why? Because in this case there is mutation in the gene ABCC2 gene, that is also known as the MRP2 gene mutations. But what happens if there is mutation in these genes? If there is a mutation in this gene, then there is disrupt the bilirubin gluconide transport. Disrupt the bilirubin gluconide transport across the canacular membrane, and that cause bilirubin accumulation in hepatocytes. Of course, if there is bilirubin accumulation in hepatocytes, then what happens? There is dark pigmentation of the liver, but there is normal liver functions. As there is mutation in the MRP2 gene, there is normal, there is accumulation of the this bilirubin in the hepatocytes, so it darkly pigmented, and but liver functions is normal. In most of the cases, the patient with Dovin-Johnson syndromes is asymptomatic, okay, or mild symptoms. And what investigations can perform, and what you see in investigations of Dovin-Johnson syndrome patient. So, in investigations, we can say that darkly pigmented liver on biopsy, increase conjugative bilirubin, and on urinary excretions, there is coproporphyrin level 1 increase. And how treat a patient with Dovin syndromes? Usually, no treatment in case of Dovin syndromes, no treatment required. Okay, rotor syndromes. This is also present in adulthood, and there is also mutation in gene like SLCO1B1 and SLCO1B3 gene. Okay, and what pathophysiology? In this case, there is affect the reuptake system for bilirubin gluconides, and that cause some bilirubin to enter the recirculations. Okay, and the clinical features like mild to moderate jaundice, patient rotor syndromes, and there is no darkly liver pigmentations, as you can see the patient in Dovin syndromes. On investigation, there is increase direct bilirubinemia. Then the excretion, there is a cropoporphyrin level 1 and 3 level increase. Okay, and the liver is not pigmented biopsy. And management, usually no treatment required. Okay, usually no treatment required in case of the patient with rotor syndromes. No treatment required. And there is some teaser you can read yourself. Okay, approach to evaluating hyperbilirubinemia, and nothing. Thank you.